In this part of the afternoon, I'm going to talk a little bit about the coronavirus pandemic and the implications for patients with LAM. I'm going to introduce the coronavirus with some stuff that probably most of you already know, and a little bit of LAM specific data, such as there is. COVID-19 is the illness caused by the severe acute respiratory syndrome coronavirus type 2. There have been other coronaviruses which are similar to SARS-CoV-2. The original SARS, severe acute respiratory syndrome, was a pandemic in, I think, 2005. And then we've also had the Middle Eastern respiratory syndrome, another potentially fatal for some people respiratory infection spread by a coronavirus. This is an electron micrograph of a coronavirus. These are the little spikes that it uses to attach to the lining of the airways to gain access into the cells. And actually these little spikes are supposed to make it look like a crown, hence coronavirus being the name. So the infections caused by a coronavirus can vary a great deal, and this is one of the things that makes it difficult. So some people can have no symptoms at all, yet despite this have coronavirus infection. It's the most common type of recognizable infection is an infection with predominantly upper respiratory and some systemic symptoms. So cough and fever are very common. Muscle aches or myalgias and fatigue are also very common. Some people will get diarrhea. Some people will lose their sense of smell. Some people lose their sense of taste. For some people, and it may follow the typical type of cough and fever infection after about 7 to 10 days, will develop a pneumonia-like illness. And one of the identifying features about COVID-19 pneumonia is how low people's oxygen levels are when they have coronavirus. And not only can you get pneumonia with severe respiratory failure, these patients also have inflammation of the small blood vessels, which causes clotting in these vessels, which can cause blood clots in the lungs, pulmonary emboli. It can block the kidneys with small blood clots or microthrombi, and kidney failure is a particular feature of advanced coronavirus infection and can sometimes cause strokes. So there's a whole range of severities of coronavirus, and of course everybody's aware that this tends to preferentially affect people who are older, and we'll talk about risk groups a little bit as to who's most at risk of severe disease. So we've not had anything like this before. We had SARS, but that burned itself out. MERS was a problem. There are other severe infections have been localized geographically. We haven't really had to face anything like this for a very long time, perhaps since Spanish flu at the turn of the 19th century. It's such a problem because the disease is highly infectious. Each person typically affecting 3 or 4 other people when they have the infection, if they don't exercise social distancing. So that you can see how that will spread very widely. It's a relatively new virus for these types of pandemics, and although there was a lot of research done into SARS and MERS originally, because they didn't develop, perhaps we lost interest in pursuing those infectious agents a little bit, and so not so much is known about coronavirus, how it works, how it gets into cells, how you might target it particularly, and of course that means there's no vaccine. There's no specific treatment for coronavirus at the moment. I'll talk a little bit about the trials that are going on. There've been some developments, which I'll highlight a little bit. The other thing is that in the early stages of the pandemic, of course, it was difficult to access tests. And in early disease, if you have a swab test, and even if you process it correctly and do everything right, there's a high chance that probably about 20% if you just have one swab taken that might be negative even if you have the coronavirus. One of the other difficult issues for people working in the health service, for the economy generally, and for resources like having enough oxygen, having enough ventilators, having enough ITU beds, is that the illness usually goes on for a long time, and you hear about people on the intensive care unit for weeks and weeks, and that's very resource intensive, of course. There has probably been a slow response by lots of countries, and that's been very well documented. And actually, probably the best time to look at all this is when we're more in control, to look at these things properly. And of course, there's been a very big change needed in society to combat the pandemic. So, do we know anything specifically about coronavirus and LAM? Well, of course, the main worry for women with LAM was that the initial data suggested that people with lung disease were much more likely to be prone to the severe forms of coronavirus infection. Like many things, as LAM's a rare disease, there's no specific data on LAM particularly. I've heard of only a very small number of people who've had coronavirus infection with LAM. This is a patient with LAM. You can see she has pretty mild disease. I don't know if you can see easily, but there's only one or two cysts visible here, and this little patch of white change. This is at the back of the left lung here. That's called consolidation. That's pneumonia caused by the coronavirus. All the people I've heard of with LAM have recovered. So the risk of severe infection from coronavirus is likely to be a little bit increased. If your lung function's reduced significantly, I don't mean just a little bit low, I mean properly reduced with an FEV1 perhaps lower than 70% of the predicted value particularly. Because rapamycin modulates a lot of key cellular processes, there was always a consideration that if you were taking rapamycin, that you're at more risk of severe disease. That may in fact not be true, but we certainly warned people taking rapamycin and people whose lung function was outside the normal ranges that they should shield for 12 weeks. As I say, the LAM experience hasn't been too bad. We've seen a small number of people, and I think that's down to people being very sensible, to socially distancing, and a lot of people have had to shield for the whole time, and that seems to have been effective. As I say, in the people who've had LAM and who have recovered, the experience, although it was very unpleasant for them, everyone has recovered. And to my knowledge is out of hospital. If you look at other diseases, so mild asthma, for example, which might equate sort of similarly in terms of lung function to and airway problems to mild LAM, there hasn't been a big increase in severe disease for those people. So maybe things haven't been quite as bad as we were expecting. The people who do have to be careful, really, and this won't be news to people particularly, if you have severe LAM. So if your LAM's advanced, if you're breathless walking on the flat, you're using oxygen particularly. Everyone over 60 is at increased risk of severe infection from coronavirus. People from Black, Asian or ethnic minority backgrounds seem to get coronavirus more frequently and also seem to be more at risk of a poor outcome. So patients with LAM and everybody from those backgrounds must be more careful. Being overweight, particularly if your body mass index is over 40, and that is reasonably overweight, is at increased risk of a poor outcome. And other significant illnesses, particularly diabetes, puts you at risk of a more severe outcome. And most of the people in these groups, I think, have been being very careful, certainly of the LAM patients I've been speaking to. One of the LAM specific things that people have been asking about a lot is, should I stay on rapamycin? So the evidence, if you look in the literature, in the scientific research, is quite mixed. So there was an existing paper which showed that that rapamycin reduced the expression of what might be a protective protein on the lining of the airways, and suggested in that study that rapamycin might allow the coronavirus more traction when it's trying to get into the airways. And so we thought that might be a bad thing. You all know now, those of you who didn't switch off after my machine learning presentation, that this is data analysis where they've looked at lots of different cellular pathways and how they interact, how they're affected by the coronavirus. And what they notice is that the signature of coronavirus-infected cells is a little bit like the cells where mTOR is overactive. And sirolimus or rapamycin, the treatment for LAM, of course, has been suggested to suppress some of the adverse effects of coronavirus, particularly preventing against the more serious forms of the illness where the immune system seems to become unregulated. So actually, sirolimus may be good for severe disease, and there are talks of doing trials of treatment of sirolimus or rapamycin for coronavirus infection. And so that sounds like that's likely to happen. So the advice at the moment is, if you have LAM and you're well, you should stay on rapamycin and do your best to avoid the virus. We suggested that because we didn't know how long the lockdown would last. We didn't know how long the coronavirus would be around. And if it's around for a year, we don't want people to lose a year's benefit from rapamycin, because we know LAM can become more active afterwards. If you're unwell and severely unwell, we have suggested that people stop rapamycin. That may not be the right thing to do. And in fact, certainly one of the people that was admitted to hospital with LAM didn't stop rapamycin, because they didn't actually know they had coronavirus at the time, and only found out when they'd been discharged and recovered. But we're saying we should probably stop rapamycin, and that's the same advice as they're giving from the LAM Foundation, for example. And this is based on what we think is probably best. A little bit of a word of warning for the people in the tuberous sclerosis community. They have advised that people with tuberous sclerosis should stop their mTOR inhibitors if they're using them for kidney disease. The advice for people with tuberous sclerosis and significant LAM is different, and so most of those patients with LAM and tuberous sclerosis have stayed on their mTOR inhibitor, whether it's sirolimus or everolimus. So at the moment, if you're on rapamycin, we suggest you stay on it. Do everything you can to avoid the virus. Obviously, the LAM Centre would be happy to discuss with your doctors if you were admitted to hospital about what to do with that following that. So, what's happening to combat the virus? Again, this isn't really news. Contact tracing is slowly coming online. This is going to be very important when there's no real effective treatment, no vaccine, no preventative medicines. Avoiding exposure to coronavirus is going to be very important, particularly if we're going to try and get society sort of functioning again. So that's going to be an important thing. Understanding how the virus spreads and what protective measures are useful. So the modelling of how the virus spreads through communities based on data on who becomes infected is critically important. And other specific studies to show how different measures might reduce transmission are useful. There was a review in the Lancet a couple of weeks ago, I think 2 weeks before this presentation will go out, I think, showing that social distancing and face masks all worked. It's not very surprising, is it? But it's good to have that data there. As you know, there are vaccine trials. The big one is coming out of Oxford, but there is another UK one which is a slightly different type of vaccine. And actually, drug companies are already making the vaccine, scaling up production, getting things mobilised in the hope that if the trial's effective, then there won't be a big lag time before we have enough doses of it to treat everybody we need to treat. Of course, if the trial fails, the drug company is going to take a big hit, but it's a brave and sensible thing to do by them, I think. And of course, there are trials of treatment. So I've never seen a research effort of this speed and this magnitude previously, and it really does feel like a lot of people are working together. For example, for the vaccine trials, as soon as the virus was completely sequenced, its genetic makeup was understood, that became public straight away. Lots of people started working on vaccines and other methods to try and inhibit the virus. For the treatment trials, we've already had several positive and negative results for potential treatments for coronavirus. And in the Nottingham hospitals, for example, patients are being enrolled every day into coronavirus studies. The big one's the recovery trial. It's an adaptive design, which means that if you have an idea, you can test the drug. If it works, then that arm drops out and it goes into practice. If it doesn't work, another thing takes its place. So they've already shown that the antiviral remdesivir shortens the duration of infection and illness by a few days. So that's helpful. It's not a cure. And hydroxychloroquine, drinking bleach, various other things, although I don't think bleach drinking was in the recovery trial, but hydroxychloroquine does not work, has no benefit for coronavirus. And probably by the time this presentation comes out, there'll be another drug will have been validated by the study one way or another. So I'll update you on the day in the Q&A. So what's happening at the LAM Centre? Well, we're all still here. Slightly out-of-date photo, but so we're all working. If you have queries, questions, then you can contact us, and we're there. You can see my relatively informal dress here. That we're phoning people mostly rather than having face-to-face appointments. But everyone who had an appointment is being spoken to. We're prescribing remotely. We're delivering rapamycin for those people we prescribe to their door. Don't like the gift wrapping very much, but everybody's getting their medicines. We're contacting them. We're available for help and support. And at the moment, we're really planning our post-COVID care. How are we going to work out how we can do face-to-face appointments? We'll probably be doing more remote care in the future, which actually a lot of you will like. I know you probably enjoy coming to Nottingham on a rainy November day, but we can probably improve remote care and have less face-to-face appointments in the future, I think, as a consequence of this. We've really just got to work out how we can run the best service we can, minimising the risk of spread and the risk of failing to diagnose LAM-related complications to maintain the quality of the service. One likely development that's going to be coming, I think, is people having home spirometry. One of the big challenges is that all the blowing and the coughing that happens when you do lung function tests means it's an aerosol generating procedure, and it's difficult for lung function to put people rapidly through the lab anymore. And in fact, at the moment, no lung function tests are happening at the Queen's. And actually, we will be able to start doing a few patients, but what we'll probably move to is people having remote monitoring, having their own little spirometer. You can get one of these for 150 quid now, and upload the data electronically. And actually, that might be better for detecting early changes than coming once every 6 months anyway. So that's what we're trying to do.
Thank you, Simon, for a really comprehensive introduction to COVID-19 and the issues around it. So now we move forward to questions on the subject. Thank you for sending all of those in. As you can perhaps see, if you're looking at the questions themselves, they've been prioritised. So Simon, if you're ready, shall I leave you just to kind of go through them in the order that's got the most votes? So Sarah Wood's question, first of all, about information about vaccines.
Okay, thanks, David. So, Sarah Wood's question was got the most likes. We've also had vaccine-related questions from Audrey Ferguson and Tracy Samways, and I was going to sort of cover those together a bit. So Sarah asked if there was information regarding vaccines that wasn't generally seen in the media. Most of the data is available in the scientific literature, and you can get an idea, actually, if you look carefully on the internet about what's going on. As I said in the talk, and perhaps just in a little bit more detail, there's been a huge mobilized effort in vaccine research. And the trials that people know about, the Oxford one's the largest. It started 23rd of April. And they think that they should probably have an idea in about 6 weeks from that date as to at least some idea of whether the vaccine's effective. There's another vaccine trial running out of Imperial College in London with a different vaccine, and there are also human trials in the US and in China, which are active at the moment. In actual fact, there are over 150 different vaccine efforts and groups worldwide, which are running at the moment. So there's a really big effort. AstraZeneca are already producing the Oxford vaccine and trying to scale up production, and there are global consortia to try and deliver vaccines once they're proven to be efficacious. There were a couple of questions about, will it be a live vaccine? Can I take the vaccine if I'm using sirolimus? The question is obviously no, but for people who don't, some vaccines are attenuated strains or weaker strains of the real virus. So it allows you to, usually those viruses don't make you ill, but you do produce antibodies to them. So if you get exposed to those, you don't get illness, but you get protection against the real thing. Those vaccines, if your immune system's compromised, actually even the weak virus might cause a problem. So people who are on rapamycin and who have other serious health problems can't take live vaccines. The vaccines that have been developed for coronavirus at the moment are not live vaccines. The Oxford vaccine is an engineered version of an adenovirus, which causes the common cold. Engineered to take out the bit that allows it to reproduce. And it's been replaced with the gene for the spike protein for coronavirus, the little sort of pointy things that I showed you at the beginning of the talk that the virus uses to attach onto the airway cell. And so that virus makes the spike protein for the coronavirus, and the idea is that you then make an antibody against that. The Imperial vaccine, which they're working on in London, also makes the spike protein, so you make an antibody, but it does it in a different way. So they're different approaches to roughly the same thing. So we would hope that people taking rapamycin and other people with any sort of reduced immune function will be able to take these viruses in the future. The question really, the main question is, can you successfully make a vaccine against a coronavirus? That's not been done so far. There were efforts at making vaccines against the SARS virus and the MERS virus, which is coronaviruses and quite closely related to COVID. Because those became less of a problem and sort of fizzled out a little bit, low infection rates, those virus efforts sort of stalled and nothing really came to fruition. But the hope is that we will be able to make a vaccine against coronavirus, and then the next challenge will be to make enough of it to give to everybody that needs it. The next question in terms of popularity is from Kelly Vance, who's asking if there's a suitable alternative way of monitoring lung function when LAM patients are unable to travel to the LAM centre because of shielding. Well, that's an issue, and the other issue with lung function is that it's an aerosol generating procedure. So As everyone knows, the virus is spread by droplets, usually that come out of the respiratory tract, in coughs, sneezes, and breathing generally when you're in close proximity. Doing the lung function tests, as you all know, is hard work. Lots of blowing. It often makes people cough, and it causes a release of, if you're infected, of virus particles into the environment. So it's at the moment we're not doing any lung function at our hospital. One of the lung function labs is just doing a very small number of tests on cancer patients who need urgent surgery. So there isn't any lung function happening at the moment, and that's going to be a challenge as to how we assess the severity of LAM and how we monitor the response or the need for therapy. So there are a few things that are happening. We're looking at ways of making lung function tests safer. Obviously, if you don't have coronavirus, then there's no problem. So if we know people don't have the coronavirus, if we can test them, or if they've been socially isolating and they're well, then potentially they can have lung function. If they do have coronavirus, they can still have the test done. The technician will have to wear appropriate equipment for an aerosol generating procedure. And the other issue is that in order to allow any virus particles to settle, we have to wait an hour. Can't use the room for an hour. Then we have to clean all the surfaces. And so the number of people we can test in a day immediately goes down by a big factor. So we're going to have to be a bit creative about that. And one of the things that quite a lot of different specialities are looking at now is home spirometry recording, which I talked about a little bit in the presentation. You can get a handheld spirometer that's actually nowadays quite accurate for about 150 quid. And it may well be more cost effective for us to give people spirometers to have at home than to do a lung function test at the hospital. And of course, people can do they can be shown how to use the equipment. They can send their data in. Actually, they can have more frequent measurements, and it may be a helpful thing anyway. And actually, we were looking or thinking about this, and there's a research project already going on out of Cincinnati on home spirometry in LAM before the coronavirus pandemic. So we may well be looking at more remote monitoring in the future. And I think actually how we look after people with LAM is likely to change in the future. We're learning about how to do more remote sort of testing generally. So some of you might find that you're not driving to Nottingham quite as often.
Simon, there's also a question about will the proposed remote spirometry testing method be able to provide monitoring of DLCO?
No, it doesn't. That's a problem. So for someone, now we know from a lot of the work Jan's been doing, for someone with FEV1 and DLCO are fairly parallel measurements. So when one goes down, the other goes down by sort of roughly similar proportion. So in those people, you wouldn't necessarily need to measure both. So if they could have a home spirometry, that might be all you need. And then maybe you could just measure the DLCO once a year or perhaps less frequently, just as a check. For people who the DLCO is much lower than the spirometry measurement, then home spirometry might not be so effective. But that's a smaller number of people. And so, again, we'd have to look at each person and ask, is that going to be a useful way of monitoring them? Is that going to tell us what we need? Or might they actually be getting worse without us knowing? So each person would be judged as to whether home spirometry might be helpful. And we'll be able to do some lung function, probably just not as much. So we'll be thinking more critically about who needs it. On a related question about monitoring and severity, Virginia Air said that she's only very recently been diagnosed with LAM during the lockdown, in fact, and can't have lung function tests at the moment. and is asking how she can work out whether she should be in the shielding category or not. Um, the not so the shielding, really, the way we judge, we had a cutoff of spirometry values. If it was over about 70% of the predicted value, we suggested you didn't need to shield, but just did the normal social distancing precautions. If we can't measure that, the other indices of how severe your LAM might be that we would have is how bad your symptoms are. If you don't have much in the way of breathlessness and can do most things without limitation, can walk and talk at the same time, walk up the stairs without too much trouble at home, then your disease is likely to be mild. If you look at your CT scan and there aren't very many cysts visible, then your disease is likely to be mild. And we know that the more cysts you have, the lower your lung function is likely to be. And so you'll see some women with LAM who have only a small number of cysts and have fairly normal lung function. And although it's not as good looking at the scan as measuring the FEV1, you can get a fairly good idea. So I would suggest that Virginia maybe spoke to her specialist and asked about whether they felt she needed to shield or not, based on what they knew about her disease.
I was just going to lead you to a kind of broader question about coming out of lockdown, which was, are there any recommendations on which face mask to use?
Okay.
And also, when will it be expected for vulnerable category to stop socially shielding?
Yeah, so yeah, no, absolutely. So there were a few questions around this. Harriet Saunders and Sharon Hamilton, and also Julie Mullins asked a related question about what you could do if you felt breathless using face masks, but yet you needed one for work. And I mean, the important thing to stress really is that face masks are part of a number of measures to prevent either getting the virus or spreading the virus. So masks fulfill different functions according to your situation. So obviously, if you have coronavirus, you can reduce spreading the infection by wearing a mask, and that's recommended. I'm really going to answer from the point of view of people who don't have coronavirus. That the important thing is, how do I prevent catching coronavirus? In terms of preventing yourself catching coronavirus, there was a recent meta-analysis in the Lancet, I think, a couple of weeks ago, and that looked at a lot of studies. Now, these weren't randomized trials; they weren't the strongest type of evidence, but they looked at a lot of other types of studies, observational studies, about what was effective in reducing the transmission of both COVID, but the other coronavirus infections. So studies that were done during the MERS pandemic and the SARS pandemic. And what these study shows, it looks like social distancing is obviously important, and not surprisingly, wearing a face mask reduced your chance, or was likely to reduce your chance of contracting the virus. And the other thing that was helpful in reducing contracting the virus was eye protection. So yes, a mask is useful. I can't overstate how important social distancing is. There's a lot of talk in the media at the moment about let's change from the 2 meter social distance to 1 meter, so it would be much easier to go into work and into restaurants and bars, and the country can work better. The chances of you getting the virus, it comes through respiratory secretions, and it also, of course, it lands if someone coughs. Virus particles will land, and they will persist, particularly on hard surfaces, for a couple of days. On softer surfaces, they're not so long-lived. And so the area, the range of safety, the chances of you contracting the virus from someone who's had, when you're greater than 2 meters away without a mask, is really quite low. The other important factor, of course, is how prevalent the virus is in the community at the time. So most people, and actually from next week, people are going to be asked to wear masks when they're on public transport uh, and in various other situations. So what's the best type of mask, to answer the question directly? Um, it it really each mask is a bit of a trade-off between the absolute protection it affords, um, how easy it is to breathe through the filter, and how easy it is to access and change. And basically, there are sort of, I guess, three levels of masks. There are what they call non-medical masks. These are generally fabric type masks. They should have at least 3 layers. And they're recommended for reducing exposure when you're out of doors in crowded areas where it's likely that there may be um, people who have the virus, and particularly where social distancing can be less possible. So if people are very interested in this, the World Health Organization website, which is very easy to find if you just Google World Health Organization mask, has a lots of really helpful data on what they recommend. It's not the UK law, but it's it's what's recommended by the evidence. And they've got a very helpful table for people in different situations. And they recommend that for for most people who are not in the vulnerable category, that they would wear a non-medical mask when they're outside, and they would wear a non-medical mask when they were in an area such as a workplace where there wasn't always ideal social distancing. They would suggest that for people who are in the vulnerable category in those same situations, um, particularly in the workplace where social distancing wasn't ideal. And I'm thinking particularly of people who are perhaps school teachers, then they should wear a medical grade mask. And they tend to be the surgical type of mask. They're multi-layered, they've got narrow fibers. Paradoxically, the higher quality ones, often they're easier to breathe through. Um, there are specified levels, and these are the thing about a medical mask is that it's been tested, and there'll be specific standards for the percentage of small particles that the mask allows through it, and how easy it is to breathe through it. And there are different levels of protection that you can get. I suspect that that specific guidance is likely to come out on this, and we can say various different, we can say what the World Health Organization recommend. Actually, the UK government are likely to give specific advice about this. The breathability of the mask, so how comfortable it feels to breathe through for women with LAM, is an issue, and Julie Mullins' question speaks to this. So if you feel too breathless when you use a mask, what can you do? When you wear a mask, what we do know is it doesn't reduce your oxygen level, and it doesn't make you retain carbon dioxide if you're wearing a standard medical mask or a standard surgical mask. And if you feel that you're breathless in that situation, one of the things that you can do, if you have an oxygen saturation meter, you can put your mask on for a short time and see what happens to your saturations. Shouldn't change. If you're able, if you can build up, perhaps you tolerate the mask for a little while and get some confidence using it. The other thing to do would be to use it in situations where you minimize your oxygen consumption. So if you were, for example, teaching, you might want to sit down rather than stand up, not walk around too much, and perhaps use slightly shorter phrases if this is at all possible. If you really can't tolerate a mask, then the other thing that might be helpful, and the thing that does afford protection, is a face shield. They're not quite as good as masks at reducing virus particles, but it's much more comfortable to wear. And the World Health Organization recommend them if masks are not available. And that has the added advantage, of course, it covers the eyes, which is another source of entry for the coronavirus. So in terms of which masks are recommended, then we would recommend a standard fabric mask for people who are relatively well. For people who are vulnerable, especially where there's areas where there's perhaps poor social distancing, we would recommend a medical grade mask. That's all the questions on masks.
There are very few people with LAM, but has any data been kept on LAM patients who have tested positive? I know you mentioned a few cases. Is there any more data available?
I don't have any more data on that. One of the unusual, slight, I guess, side effects of the pandemic has been that most people with LAM have been socially distancing and shielding really effectively. And that's also true for other respiratory conditions. And so when I phone my other lung disease patients, so I have a big clinic for patients with interstitial lung disease, nearly everyone, because they're all social distancing and being very careful, they've had fewer general coughs and colds, fewer virus infections, and actually feel reasonably well. And so if you take these measures, the chances of getting the infection are reasonably low. Sorry, I'm just scanning the question.
One roundup question, perhaps, Simon, is how long should LAM patients shield for? Is there any way that you can guide people kind of going forward?
Yeah. So shielding is something that we recommend for people who are vulnerable and at high risk of a bad outcome. So how long people would shield for is going to depend upon several things: how likely they are to have a bad illness, or how severe their disease is. The other very important issue is how prevalent the virus is in the environment. So as the R rate is below 1 and the prevalence of the virus falls in the community, the chances of meeting anybody with coronavirus, even if you do have bad luck and you bump into someone when you're out, gets lower and lower. And so you're balancing risks and benefits to some degree here. So the shielding advice has been reduced slightly just in the last week or so. Now people are allowed to take exercise once a day, whereas they weren't previously. So the advice about shielding, and somebody mentioned that there hadn't been any specific advice particularly, and really that's because everyone has to slightly make their own degree of risk assessment as to how severe their disease is, and as the new information is coming out all the time. So if the prevalence of the virus goes down in the community, then it will become safer and safer to be outside. So the shielding criteria are likely to be relaxed, and that really depends on what happens to the virus prevalence. And I think everybody accepts we're at a critical phase at the moment, where the lockdown's been reduced a bit, and although the prevalence continues to fall, we're just hoping that there isn't a second peak in the virus. If it does continue to fall, then we're likely to see a relaxation of the shielding requirements, in the coming weeks to months. You can't give a date because we just have to understand what's happening in the community. There may be local variations. If we can get contact tracing to work, so the people that we know who've been exposed to the virus are isolated themselves, then that will dramatically reduce the prevalence of the virus in the community. And then the people who are shielding hopefully will be able to relax that before then. So all of these things are dependent on lots of factors: virus prevalence, the control measures, efficiency of contact tracing. Clearly, if we found a treatment or a preventative therapy, then that would also allow us to reduce the shielding requirements. I see there's a fairly recent question about asking about hydroxychloroquine and azithromycin, about reducing disease severity, and also it was suggested that perhaps some of these treatments might stop you from contracting the virus at the moment. At the present time, there's no evidence that any of those things are effective. So really, we are, to reduce the shielding, we're really waiting for the virus prevalence to go down, for contact tracing to start working. Obviously, if there were a vaccine available, that will be a game-changing thing. But as I've said, that's likely to be a while away yet.
I think we're going to have to kind of go to a final question, which is not related to the virus, but comes back to LAM, which was from Penny McKee saying, can you clarify in medical terms what causes lung pain in LAM? This pain can be waves of pain across the lung area or a heavy pulling down sensation. Is there anything you could say to that?
So there are chest pain is a symptom that a reasonable number of women with LAM get, and there are different causes. The easiest one to understand, and probably the most common cause, is if you've had pneumothorax and if you've had surgery for pneumothorax, or if you've had chylus pleural complications, or maybe interventions for that. Then the scar tissue between the lung and the chest wall will cause the lung to stick to the chest wall, causing dragging or pulling sensations when you particularly breathe deeply. And so that might get worse when you exercise, but also when you stretch, when the lung slides over the chest wall, if you breathe deeply or cough, these things will happen. Some chest pain isn't a symptom usually of uncomplicated LAM on its own. There are many other causes of chest pain which may occur, and abnormal breathing patterns because of breathlessness can give you unpleasant sensations when you breathe also, which some people find painful. So it's a multifactorial thing. I think if you get persistent pain, obviously you should have that looked into to see if there's any other cause for that, particularly if you haven't had pleural complications of LAM. Most people who've had a pneumothorax and then had an operation to prevent further pneumothorax will tell you that they got pain afterwards to some degree, and they have those symptoms. And sometimes they persist for a very long time, albeit sometimes they fade away, but they're often there in the background. If you have sudden onset of chest pain, clearly that might be a pneumothorax or as a possible complication of LAM. So you should have that evaluated quickly. I don't think that particular question was related to sudden pain.
All right, Simon, thank you so much. We've got a few other questions. We'll see if we can answer those offline at some point if there are any that we feel are pertinent. But thank you for going through COVID-19, going through AI and answering so many of the other questions so well. And thank you also to Suzanne and Debbie for their presentations and their papers. And I think for the whole of the kind of LAM community, I can say we really, really appreciate the fact that we have contact with you and with the team, and that we can see the kind of direct relationship between the research and the treatments and the way that kind of impacts on people's visits to Nottingham, to the LAM Centre. So thank you very much.
Well, thank you, David, for pulling all this together, because it's been nice to be able to sort of meet up with everybody only online and to be able to present our work. So very grateful for you for pulling all that together and cajoling us into.
Well, thank you. I think you've all done a really good job, and I know it's not easy to put yourself on camera and do these presentations and so on, but I hope everyone's appreciated it. So yes, that's all that remains for me to say is really thank you to everyone involved. Thank you also to Leanne for her early presentation. Thank you to Nick for putting it together technically. How do you think it's gone?
I think it worked. I mean, we had a bit of a hiccup in the middle, but such is the internet.
Yeah.
So yes, thank you for joining us, and we hope you enjoyed it as well.
Yeah, and do let us know. Obviously, we're really interested to hear your thoughts. Apologies for the technical glitches, but given the state of the nation, and hopefully this has been a way to reach you all and to bring the LAM community together. And if you think it's a good idea for the future, well, let us see what we can do. So all I can say for now is thank you, stay safe, and let's hope we all meet at a physical meeting again before too long. Bye-bye.
Bye-bye for now.